Hello everyone, I am Dr. Priyank Patel and we are back to you with the Bombay Spine Society case of the month. This month we have Dr. Aditya Kashikar, who is a consultant spine surgeon working out of multiple major hospitals in the city. Over to you, Aditya.
Hello everyone. I would like to thank Bombay Spine Society for giving me this opportunity to share my experience. This is a case of 70-year-old male patient who presented to me with history of RTA near Palghar. He had a fall from two-wheeler. When I saw him, there was difficulty in moving all four limbs. The upper limb were more involved compared to lower limb. He was not able to walk for last 3 days post fall, and there was gallbladder dysfunction also. Initially, he was taken to nearby hospital in Palghar, and on day 3, he was shifted to tertiary care hospital where I saw him. As per the history, I suspected cervical spine injury, and when he came, he was already catheterized. Examination-wise, grossly, the upper limbs were more involved with around grade 2, 2+ power, and lower limbs were around 3, 3+ power. These are the MRI images showing severe cord compression at C3-4 and C5 to C7 level. These are the axial cuts showing severe compression at C3-4. This is at C4 body level and at C5, C6 and C6-7 level. CT scan didn't show any gross instability or fracture at any level. So the probable diagnosis was acute post-traumatic central cord syndrome, as there was chronic cervical cord compression and patient had hyperextension neck injury. As a result, his upper limbs were more involved compared to the lower limbs, and there was affection of gallbladder as well. At this stage, clinician is always under dilemma whether to operate or whether to conserve this patient. So I went through literature. There were two group of studies I came across, one suggestive of conservative and one suggestive of operative treatment. The conservative group was saying that neurological recovery seen after conservative trial was complete in their studies, and they were saying that if we touch patient surgically immediately post-trauma, already there is cord edema, and post-surgery the cord edema will further increase and it may further deteriorate patient's condition. So better not to touch that patient and treat them conservatively. And in their studies, the results were quite impressive. So other group which were in favor of surgery, they said that if the patient is in subacute period where already 3-4 days have gone past post trauma and neurological status is plateaued, then in such patients offering surgery gives very good result. And obviously if there is any instability, one has to definitely stabilize the patient surgically as well. So level of evidence in literature is quite limited about this condition. If patient has mechanical instability, the role of surgical is critical. Perform early decompression in patients with continued spinal cord compression. The timing of the surgery is very less clearly written in literature because results are mixed. And wherever surgical intervention was done, they showed that the neurological improvement is early with shorter hospital stay and shorter intensive care stay as well. So I discussed the same thing with patient's relative and patient, and we decided to go ahead with surgery. I did posterior cervical laminectomy from C3 to C7 without any instrumentation. I decided not to fix this case because there was no evidence of fracture or instability. Patient was old age-wise with relatively stable spine. It involves less of operative time as well, and in my hand and experience, I haven't had any post-op kyphosis in long-term follow-ups as well. Immediately post-op only, patient started showing neurological improvement. There was flicker notice in fingers, and eventually over a period of around 3 to 4 months, he recovered completely both in upper and lower limbs. And now he's a walker He walks without any support. These are the post-op images taken at 6 months follow-up. X-ray showing good cervical laminectomy. These are the MRI scans showing good cord fallback seen in T2 sagittal images. The axial cuts showing good cord decompression at multiple levels. This is the clinical video where patient is walking without any support, and he's very happy that he's back to his normal routine.
Thank you, Aditya, for an excellent case. It's always been a dilemma for a spine surgeon whenever we get a cervical trauma, especially those patients who don't have an overt fracture or instability, and they present with an acute neurological deficit. So that discussion is always there as to do we do it early or do we do it late, and do we do it at all. So this was an excellent presentation which taught us if the patient generally does not have any fracture or does not have any overt instability, you can wait and see if there is any neurological improvement. If there is a sustained neurological improvement, you could probably wait. But if the patient's neurological improvement has plateaued, then a surgery as simple as a cervical laminectomy can give out an excellent result. So thank you so much, Aditya, for sharing your case with us. Thank you everyone for having watched this. Have a nice day.
Thank you.